Good evening, everyone. Thank you for joining our online CME live today from Gleneagles Hospital, Kota Kinabalu. My name is Lucy, and it is with great pleasure that I welcome everyone to our online CME live event, especially to those who have followed and support us from the beginning. We are now live from our presidential suite at the 7th floor of our building. Just to let you know that Gleneagles Hospital, Kota Kinabalu, we have 2 presidential suites available for our patients. As you can see in this suite, we have separate patient room, sitting room, and also a pantry for patients' convenience. For all healthcare professionals out there, especially to the frontliners, I know you are working hard throughout this MCO in keeping our community healthy and safe, and we are truly grateful for the support from all of you. Your dedication, commitment, and courage deserve our deepest gratitude and admiration. And also, thank you for joining our live talk today. Today, we have Dr. Chuah Chyi, our resident orthopedic spine surgeon and pain management specialist, to share with us on safety and recovery expectation in spine surgeries. Before we start, allow me to brief you a little of Dr. Chuah's background. After obtaining his master's degree in orthopedic surgery, Dr. Chuah continued his spine surgical training in Singapore General Hospital. He returned to serve as the head of spine service for the state of Sabah, Malaysia from year 2009 to 2015. Dr. Chuah is very competent in both advanced and general spine procedures. He introduced minimally invasive spine surgeries to Sabah and is a pioneer in promoting safe and personalized spine services by introducing the intraoperative spinal cord monitoring and spinal navigation usage. He has special interest in pain intervention as part of his spine consultation, giving his patient alternatives and choices for their pathologies. Dr. Chuah is frequently invited as a guest speaker and spine educator for international spine surgeons in this region, promoting minimally invasive spine surgeries for the next generation of spine surgeons. He is the key opinion leader for various orthopedics and pharmaceutical products and actively promoting osteoporosis awareness among the community. If you have anything to ask Dr. Chuah, please send it to the comment section, or you can WhatsApp your question to the phone number as added below, and Dr. Chuah will try to answer your question towards the end of our session. Without further ado, I will pass this session now to Dr. Chuah. Good evening, Dr. Chuah.
Thank you, Lucy. Hello, everybody. Hello, all my friends around. Thank you for joining us this lovely evening. I think the weather is nice today. Throughout the years we've been practicing spines, I've been having feedback from a general practitioner like you all, and also my patient and all. They all sometimes they are not very aware of what is actually the safety and the recovery expected in the spine. So I would like to take this opportunity just to share with you what we do expect from the recovery, and also what are the safety features that we have in spine surgery. Trust me, not everybody who see a spine surgeon will end up doing a spine surgery. So, but however, in a certain condition that a patient have no other choice but to engage in spine operation condition, like there's obvious neurological compression, especially the motor weakness for the patient, or there's a rapid progressive condition like a tumor or infection involving the spine, and they have to end up agree for an operation, or patient who came with a gross instability, either trauma or due to a progressive or degenerative process, or they have done something before that and they fail to improve on a conservative and a non-surgical method of a treatment for their spine condition, or they need a revision, or because they have done an operation before and now there is a subsequent deterioration of the spine condition and they need to be revised. Or sometimes it's also very demanding patient. When we talk about demanding patient, we are not talking about activity demanding, means they want something more in the body, they are heavily involved in sports, they have to manual worker, they want things to be able to, the spine condition to be able to cater for their daily activity. These are the patients who may end up agreeable for a spine operation. So when we talk about spine operation to the patient, so they all usually they pause a bit, they are a bit apprehensive, they are scared. So Lucy, what do you think the patient, why when we offer that spine operation, they are always scared about it?
Maybe from my point of view, doctor,
yes.
Maybe they scared because they have less knowledge about the new technologies that we have, and also maybe about the recovery process, doctor. Yeah, on that part.
Yeah, I think you are right, Lucy. So always tell the patient that it's actually normal to be scared. If someone were to operate on me or myself, of course it's an invasive procedure. It's every reason to be scared, and it's always reassured patient it's normal to be scared. However, patients usually sometimes they are scared because they are ignorant, or they are not being well informed of the condition that they have, or they are not informed what to expect during the surgical. And sometimes they are not even know what are the safety margin that we developed over the years for modern spinal operation itself. And sometimes they are scared because they got no knowledge of what to expect during the recovery process. So let me bring you to the next half an hour in the two big category. First part is a safety in spine surgery. Of course, the second part will be what to expect during the recovery, or what to expect during the surgical process. Okay. We will start by saying safety in spine surgery. As you all know, spine surgery is actually a very delicate operation, and over the years we have been doing this spine surgery since 2006 in Kota Kinabalu, and we do this day in and day out, and I would like to glad to say that about 70-80% of my job involving the spine, and we are very dedicated just to do the operation on the spine. And with that, I would say that when the dedication come in, we are able to identify a non-spine to a spine pathology. Sometimes the patient come to you with a leg pain, so they may come to you, they suspect this condition of the leg, but however when we examine patient, we find out actually it's a radiculopathy pain, is actually coming from a lumbar spine, so that we are able to identify the main pathology, and we are able to order an appropriate or precise investigation without wasting the patient a lot of other unnecessary resources. So if we think that there's a component of neurological compression and it's very obvious, we will order MRI straight instead of doing an X-ray, then followed by a CT scan, followed by MRI. So the patient end up actually wasting a lot of time and money involved as well. So once the diagnosis is made, we are able to explain to the patient adequately and with illustration to show on a CT scan and MRI, and able to discuss with patient what other different type of treatment options that they may want to engage on. And we at the same time we are able to detect any existing severe condition like red fat cell, which will require immediate action and actually treatment as well. So once patient is diagnosed and we end up doing agreeing for operation, we will want to perform operation, we will follow up patient and we make sure patient have a smooth recovery. All these are actually adds to the safety margin of the spine operation if ever the patient have to engage in the spine operation itself. Of course, secondly, will be the operation will not be done appropriately if we don't have adequate equipment or technology involved. The equipment and technology is advanced that it's only available if the hospital is willing to actually invest in the latest gadget that we have. So of course, for spine surgery, we will require MRI and ultrasound, CT scan. We even involved in a high spec microscope for the patient. And I'm glad to tell you that we are actually doing a lot of this navigated spine operation, which in a normal term we call it a robotic operation, or in a scientific term we call it the image guided surgery, IGS. So we have actually a IGS machine in a Gleneagles hospital, and Gleneagles machine, the advantage of this IGS machine is actually you will be able to perform the operation more accurately, and of course because the image will be the real-time instrument and the image will be merged together, so that the machine will be able to tell us at any one point where will be our instrument, where will be the trajectory of the instrument going to go through if I go through the same direction. So therefore, with all this image will be less radiation to patient. We don't have to shoot the X-ray all the time for the patient. And of course, with a better understanding of the trajectory and the screw placement, we are able to minimize on the invasive. We are able to perform a minimally invasive operation for the patient. So the application for minimal invasive IGS is mainly essentially for very severe degeneration with very abnormal anatomy. Patient have been done operation before, the anatomy may not be a true textbook type of anatomy. It may be a bit different. We may not able to see the pedicle for us to place a screw safely. And condition like previous surgery with a decompression where the anatomy landmark are no longer true again, and or using the navigated probe to determine correct trajectory of pedicle screw, we are able to judge the screw will stay inside the bone and not protruding out from the bone, and actually may be endanger the surrounding structure. All this will actually add to the safety margin of the operation itself. Thirdly, of course, I'd like to say that nowadays a lot of operation, mainly most of operation, we actually using intraoperative nerve monitoring. In short, we call it IOM. So why is IOM needed? So IOM is needed because there are some potentially unpredictable things may happen. Not every spine are the same. You see, some when we perform the operation, there is an abnormal spine anatomy that we may encounter, so that it may not be the textbook type of spine anatomy that we see. So that the nerve structure may be different, and the root of the nerve structure may be somewhere in the path of where we're supposed to do operation. So IOM will come in this kind of condition. Secondly, of course, the instrument-related injury will be minimized because we're able to identify where's the nerve. Of course, by doing some manipulation, sometimes we actually compromise on the vascular of supplying the spinal cord, and this may actually cause some spinal cord injury from the vascular point of view, especially during the scoliosis operation. So this is actually, IOM is actually quite mandatory for this kind of condition. So of course, IOM cannot be done unless there's a team approach by surgeons, neurophysiologists, and anesthesiologists as well. Okay, so the function of IOM is sort of the same as what you do when you drive a car. So Lucy, what do you think? Do you drive a car?
Yes, I do.
Does your car have a reverse camera and a reverse sensor?
Yes, doctor.
What do you think that this gadget in your car, that how do you improve on your driving skill?
With the sensor on my car, there, it gives me more confidence in driving, doctor. Yeah.
I think Lucy, you are correct, because a lot of time we have been driving car for 20-30 years. I'm sure you are pretty able to park your car sideways, reverse parking. But sometimes things like kids are running around, the small dogs or even animal running across, then it may actually bang into something. So this reverse camera will give you extra confidence in driving your car because it gives you a tactile, audible feedback and also a visual feedback as well. So the same goes for the intra-operative monitoring IOM. So that it gives you a continuous monitoring of your spinal cord function as well. So the principle behind is actually the same thing is what is on the complete circuit of your electrical board. So you have a battery and you have a light bulb. The light bulb will only light when the circuit is complete. So the same goes for the spinal cord. You see, the motor and the sensory will only function if there's a complete in the spinal cord and the neural element. So that this monitor will actually have a monitoring, see whether the continuity of the circuit, in other words, the spinal cord and the nerve element, make sure there is no discontinuity. And this, how the role of IOM is actually act continuously. So that it's not like when we press a button only it start to function and test. No, actually it's during the operation it actually monitor the spinal cord and the nerve function continuously, and it will able to tell us by visual and also by audible feedback. They give an alarm and also the color changes on the screen. It able to tell us even before the injury occur. So in other words, what they mean is if you are very close to the nerve, it will able to tell us you are actually very close, so they be careful. So when you actually touch the nerve, the audible sound and the color will be different. So it actually incidentally injured, then touching more than that, if you show the red color sign, just like your reverse sensor for the car. So when you are a bit further, you will, but when you are even nearer, the sound and the frequency of the alarm will be increasing. It's almost the same as a car reverse sensor. So they're able to do this continuously without have to interrupt the operating process. Mean I can continue to do my operation without having to stop and let the machine work for it. So that so the operation will carry on as usual, but at the same time the IOM will actually have a background check and balance on the operation to increase the safety margin of the patient. So, and this is actually real time. It's not recorded and we ask someone to interpret the report. So it's actually real time, so that it gives us a lot of benefit for the during operation. Of course, this will increase the safety margin of the operation. How they monitor the spinal cord, there are through a few technique that they actually do, and one of these is called the MEP. MEP is actually transcranial electrical motor evoked potential. It actually stimulates the brain, the skull, and let the signal go through your skull to your brain, to your spinal cord, down to your limb, the muscle. So the sensor will pick up the sensation and the movement of the distal limb. So that actually is a whole loop. So the other technique is called SSEP. It's called somatosensory evoked potential. So it stimulates from below and pick up the response from the brain. So your brain wave. So that there's a both way. One is up down, the other one is actually down up. So these are actually pretty much monitoring the whole spinal cord activities. The other third one will be the EMG. It's called the electromyography. So this is actually monitor the individual nerve root rather than the nerve root that exit from the spinal cord down to your muscle. So anything that happen or irritate the nerve root will actually trigger the muscle response at the limb, be it be the lower limb or the upper limb. So that will actually monitoring the nerve root. EMG is mainly for that. So in what condition do we need a MEP or SSEP? Things like when you do a scoliosis operation and operation involve anterior cervical discectomy fusion, ACDF for the neck, or posterior cervical operation, or even some thoracic fusion, either a degenerative condition or a trauma or a tumor that of the spine, or we do a corpectomy, meaning taking out the whole entire body of the spine, or when we do a decompression for the spinal cord called a myelopathy condition. This will require MEP and also SSEP. Sometimes what we can do is the machine will enable us to do a screw test as well. When certain conditions that require an instrumentation to be inserted. Sometimes instrumentation, the screw is inserted right in the correct position, then should not be a problem. If the screw is inserted slightly invading into the canal where there's a potential injury to the spinal cord, then the machine will be able to tell us that this is actually because of the proximity of the screw to the nerve element. When we stimulate the screw, this stimulation will actually stimulate the signal in the nerve, but it will not damage the nerve because the voltage is very small. So with a bridging into the canal, and without bridging, the signal will be changed from green to the yellow, from the red. So the nearer to the spinal cord, the nerve element, the color will change. Therefore, be able to tell us whether this screw is inserted appropriately, whether the screw that we inserted is actually going to impinge on the spinal element or not. So the screw test. As we evolve now more and more we are doing a smaller minimal invasive operation. A lot of time we actually need to go through the muscle fiber without cutting the muscle. For example, anterior lumbar surgery, as you see on the graph, the instrumentation is actually going through the psoas muscle, which is actually on the side of the lumbar spine. So, and you will know that actually in the psoas muscle there's a lot of lumbar plexus coming in and out. So that when we do going through blindly, there's high chances that we may actually injure the lumbar plexus, therefore causing a neurological deficit down the lower leg. So this nerve stimulation is a probe. Actually, by pressing a probe on certain area of the psoas muscle, we are able to stimulate, and if the probe is very near to the particular nerve, then they will send a signal and it will tell us that actually the nerve is actually somewhere between 1 cm from the probe, the tip of probe, or 2 cm from there. So we actually adjust ourselves the entry point for us to go through the muscle without causing a damage to the nerve itself. So it's actually nerve stimulation for us to increase the safety margin. So for EMG, I say it's actually monitoring the nerve root the nerve root, particularly the nerve root, and this is actually good when we do a lumbar decompression surgery and conditions like collar equina surgery, lumbar interbody fusion, when the instrument and the case are going into the interbody space and the disc space, lumbar pedicle screw insertion with instrumentation, total disc replacement, or even sometimes cervical decompression and fusion. So like I said before, they not only monitor the lower limb, because the cervical spine also give up the cervical nerve root to the upper limb. So that if anything involving the nerve root to the hand, we can actually use the EMG actually to monitor it. And this monitoring of EMG is actually very specific. And you say on the graph that the picture is, there are certain muscle that is a key innervation root that innervate the muscle. Like you say that for bicep it may be a C5, C6. For lower limb tibialis anterior will be a L4, L5. So if you are doing anything level on the L4, L5, you have to monitor the tibialis anterior so that they will give specific instruction, signal changes that if you have a potential of damaging the particular nerve itself. Okay, so next now come to the second part of our talk. We are talking about what we expect in the recovering period of patient. So Lucy, I want to ask you a question again. Sure. So if your family or one of your friends or yourself is going, when the doctor offer you operation, that you understand that there's no other way but to actually engage in operation, what actually come to your mind that actually immediately when you're being told you need an operation?
All right. From my point of view, for example, from a family member's point of view, when such thing happens, first thing that comes into my mind would be maybe how many days I have to take leave to be to take care of my family members, and also maybe the recovery process, and also maybe how to prepare myself during the admissions, and also after discharge, what should I do, something like that, doctor.
Yeah, I think there's a lot of questions coming in your mind whenever you are asked to do an operation. So that the 1,001. So I would like to divide it up into what are the things that we expect during the admission, and the second part will be what we need to expect during the recovering as when we are discharged home. Okay, so let us start off first with while being hospitalized. We do expect the unexpected things to happen here. So patient will ask, definitely they'll ask, do I need a caretaker? Is a caretaker necessary during my admission? Yes and no, but most of the time not necessary. Not absolutely necessary we need a caretaker all the time, unless the patient is actually truly dependent. Patients who are not able to move due to lower limb weakness, or trauma patient who have been paralyzed, they are not able to even to take a cup of water. So of course there will be added advantage if there is a caretaker around. Other than that, the nursing staff are actually very well trained in caring for surgical patients in a ward. So caretaker may not be necessary most of the time. Other question they may ask is actually, how do I lie down on the bed? So do I lie down normally as a supine, will look at the ceiling, or I need to be prone position? Because a lot of patients actually ask me, when the operation at the back, can I actually lie on the scar and the wound there? Of course, I will say that yes, because the wound is actually quite stable after the operation. So they can actually lie down as comfortable as they are. They sleep. If they used to sleep on the lateral position, they may actually sleep on the lateral position after the operation. So there is no fancy rules that they actually have to be prone position, death in prone position, or they be in the supine position all the time. So however, we do advise patients to have some pillow down the knee, because by doing that, they flex their knee and flex their hip, they actually relax the actually musculature over the back, so that the operative part will be less tense for them. They'll be more relaxed, and of course that will actually reduce the pain post-operatively. Is ambulation possible? Can I walk after the operation? Yes, of course. If you are able to walk before the operation and after recovery from operation, of course you are allowed as tolerable as possible without much pain. If you have less pain, you want to walk on the night of operation, by all means you go ahead. I have patients who actually walk to the toilet the night and they wake up from the general anesthesia. They actually able to do their own businesses in the toilet. They are quite happy about it. So most of the time there's no restriction in turning on the bed for them, and usually they do not need any crutches assistance unless there's a pre-existing weakness. They come to weakness, they may be difficulty to walk even before operation, then they may need some help. Otherwise, ambulation is actually as much as the patient can tolerate. How about pain management? I always tell patient, when operation is an invasive procedure, so if I tell the patient there's no pain, we are not telling the truth, of course, most of the time. So a lot of post-operative pain, the pain is actually mainly more intense on the first 24 to 48 hours of the surgery. So following that, the pain score will be coming down and the patient will be more tolerable, and that is the time that we actually take off the IV and change to oral medication. The typical pain management for the patient involving like IV NSAID and also acetaminophen, actually in short is actually paracetamol. So this basically, a lot of time they actually offer a lot of comfort for the patient, and of course we do a local infiltration around the wound before the closing up the wound. And of course, if there's a contraindication for NSAID, for certain conditions like renal impairment or previous allergy to NSAID, we do offer an opiate. As you say, opiates sometimes cause a lot of emetic, nausea and vomiting, and plus minus antiemetic will be on board to make the patient comfortable as possible. Of course, some are nerve irritation patients, we do give GABA, things like gabapentin and pregabalin actually to reduce the pain. So I would like to let patients know the pain management is our topmost priority. Of course, we would like to make patient recovering from pain as smooth as possible for the patient. Patient may ask, do I really need an operation? Doctor, this is a spine operation. Do I need to be taken care in the ICU? I would like to get to say that most of the spine cases do not need an ICU unless there are certain conditions that we may need to monitor patient in the ICU post-operative. Things like patient may have multiple medical comorbid, very severe uncontrolled hypertension, or medical heart condition, recent MI, recent stroke, or they have very bad renal impairment, extensive blood loss anticipated. So like major operation, we need to be transfuse patient, a lot of patient blood product, then we may need to monitor patient overnight in the ICU. Patient like things like prolonged anesthesia, maybe most of the time is more than 6 hours operation, we may need to monitor overnight in the ICU just to make sure patient is recovering smoothly as possible. And or patient have any previous adverse anesthetic event which actually bad anesthetic experience before, we may need to monitor in ICU just for the safety of the patient. Do I need a CBD, continuous bladder drainage, and how about my bowel opening? How do I pass my motion, do my business? Okay, majority of the spine procedure, if it involve 1 to 2 level of the intervention, they do not need a CBD inserted, because for this kind of operation, the blood loss is actually very minimum, and therefore there's not much of fluid going in and out of a patient, so that we do not actually have to be invasive and put a CBD for a patient, because a lot of patients, they do not like to have a CBD inserted into them. Even in a certain condition that the CBD may need to be inserted, usually we will take it out within the first and second day. Once they are fully alert, they're able to sit up from bed and they're able to pee, then we will take it out, as long as the monitoring is not needed anymore. And of course, for bowel open, it's usually not an issue, because usually surgical patient post-op day 1, day 2, they do not need to actually open up their bowel, because for first day, second day itself, there will be less oral intake, because patients are nearby mouth, they don't have a lot of oral intake, and because there's not much of in, there's not much of out as well, so the BO usually not much problem until after 48 hours, they are less pain, they're able to move in, ambulate more, they actually can go to the toilet and actually do their business there. How about the wound care? Patient will ask, okay, there's a wound behind, so I do anything about wound, so I get my wound to be dressed every day? Usually I would like to tell patient, because spine surgery is actually a clean operation. In other words, when the patient out from the operation theater with a gauze covering it, we will have minimum disturbances of the gauze, because we don't want the ward environment to contaminate the clean surgical wound. So that unless the dressing is oozing out and soaked, or less leaking out from the gauze, then we do not disturb the gauze itself. So therefore the wound are left by itself without being touched. Little bit of staining and not active will not be changed until the patient come back for a review after being discharged. If there's a surgical drain inserted, usually it will be removed 24 to 48 hours to minimize any infection. The same goes for it, because we do not want to disturb the wound as much as possible, because the operation theater is a clean environment and the ward may not be so clean as we know, so that there will be minimum touching of the wound during the admission itself. So next step will be, like Lucy said, I think how long shall the patient be staying on? In what condition that patient is fit to be discharged? I always tell patient is actually there will be incentive if we're able to fulfill all these criteria during your stay, you are actually fit to go back. If you can do it on the second day, you are fit to go back on the second day. If you're not able to do it on the second day, on the third day, then you only can go back on the third day. Things like patient with tolerable pain, they not much of pain, they are able to convert to oral painkiller, and they are able to move out of bed, then with a minimum pain. Patient with a stable wound, there's not oozing very much from the wound, and minimum IV support means they do not need IV drip, they're able to take orally. These are patients who are actually good to be discharged home. And of course, I would like to minimally to see them able to ambulate around the room, because I will always tell the caretaker and the patient, if you're not able to move during the admission, means you are scared to move, because some of the family are scared to let their loved one to move, because they're scared if they move too much, the wound will be tearing open like that. So like I always tell patient, the wound or stitching of wound is actually very stable. It won't be tearing apart during this kind of a physiological moment around the room. So that if they are confident to move during admission, they are confident to go back. Otherwise, they will be lying at home without the confidence to actually to move, and therefore they will end up a lot of problem. Immobilizing patient at home, they may end up with a pressure sore. They have DVT, and they may have orthostatic pneumonia of the lung as well. So then if they fulfill the criteria, the next question will be, how do I go back home? Can I fly back home? Kota Kinabalu, Sabah is actually large stage. A lot of time we actually have to fly back patient from Latu and Tawa. We are flying in for a patient, and they're actually flying back. A lot of time they ask me whether is it safe for me to take a flight back, not? If it's safe for me to my family to drive me back in a car, not over the Mount Kinabalu, going back to Sandakan and Tawa. Of course, I will tell them, most of the time, if you are fit to actually being discharged from the ward, you are actually able to go back with whatever transportation that you have, and they can actually, in the condition, most of the time they will be walking out of hospital, not on a wheelchair. If they're walking in the hospital, they most of will walk out of hospital into the car. They will be in better condition as compared to when they walk in the first day itself before the operation. Normal car on an upright sitting position is always possible, because they're able to sit upright. They'll be able to fly back on the plane, because taking off and a landing on the plane, that they require the passenger to be upright position. So that most of the time they are actually able to do that without much of problem. Okay, so we are talking about this during admission. The second part of the talk will be what to expect after the patient being asked to discharge home. What do you do at home? Okay, they always ask me, doctor, you did operation on the lumbar spine or the cervical spine. Do I need to have a cervical collar on thing? Do I need to wear something brace to protect it? I would say that most of the time, less than 10% of the chances of patient that they need to be extra support externally. Most of the time that if there's an instability to start off with before the operation, and once we put an implant needs to stabilize, then the implant itself is actually enough to stabilize the spine without having to external support. If they do not have a pre-existing instability and the operation is mainly to decompress, then the operation itself will not further destabilize the spine, and at the same time they do not need an external support like bracing, cervical collars like that. So to that answer, I say most of the time we do not need patient to be on that. Okay, the next is recovery. How long do I need to take care of the wound? How long before I can actually engage in my normal activities? I would like to say that patient usually any wound will heal within 2 weeks. So if the wound, the plaster will be covered off, it will take off within 2 weeks, and the wound can be actually, they can bathe on the wound, they can actually do not need to be covered anymore unless there's a wound complication for the patient. If patient undergoing simple decompression just to loosen up the nerve, usually the soft tissue will take about 6 to 8 weeks, mean 1.5 months actually to heal off. So before patient can actually return to their normal activities. Those patients who are actually undergoing fusion operation mean they have to fuse to stabilize the spine, and by mean of fusion mean we are waiting for the bone to ingrow to stabilize it. So in that case, we may take up a bit longer. Bone will take up about 2 to 3 months, 10 to 12 weeks time duration for the bone to unite. Once the bone unite, then the spine will be stable. Then they actually can return to their normal activities. Medically, for most patients will be within 2 to 4 weeks, so they were off from work. After that, they may be able to slowly return back to their work, especially those in the office, they can return earlier. Those who are involved in manual work, they may be return a bit later. Usually it's around 2 to 4 weeks. Within a month, most of the time they can actually go back to their whatever work they have. So study has been shown that a lot of time when they go for spine intervention surgical, 80 to 95% of chances that by up to the duration of 4 years after operation, they are able to return to whatever activities or work that they have do without much of a problem. So in other words, recovering is quite expected in spine operation. Nowadays, patient will be expected to be able to return back to their normal activities after the expected period. The soft tissue is about 6 weeks and fusion is about 3 months. Duration. So for those patients who actually smoke, I would like to advise that I think you to avoid or even to cut down completely the smoking, because we know smoking actually will impair the wound healing of a patient. Of course, the same goes for the uncontrolled diabetic. Of course, for fusion operation, it will delay the bone union. Normal person may take up to about 3 months for the bone to unite. If you heavy smoker, it may take up to 4 months, 5 months. Sometimes it will cause a delay or non-union for the patient. So we always warn the patient, if you can, always cut down. There's certain area of the world that some surgeon actually will avoid doing an operation for the patient unless patient really can quit smoking before the operation. Otherwise, there will be no operation for them. Of course, smoking also will increase the DVT and cardiovascular event for the patient. So it's best we actually to cut down on the smoking for the patient during the recovering post-operatively. So for those patients who come from far, Sarakan, Tawa, Gleneagles, they are not around local KK, they always ask me, how should I return? Should I stay here until the wound heal up? Should I go back and come back again? How frequent do you need to see me? For local patients, usually I would like to see them after a week after being discharged. As you said earlier, I do not disturb the gauze during the admission until patient discharged unless there's a certain complication on the wound. So the patient will go back on the gauze. Usually when they return about a week, I will actually do an inspection of the wound, because by then 48 hours the wound will seal up. So any external contamination unlikely to actually penetrate deep inside the wound. So it's safer for the patient itself. So for 1 week, I would like to ask them to return and do a wound inspection. At the same time, I need to check on their pain control, whether this optimized the medication I give them is enough for them, whether there's still a lot of pain, do I need to change the medication for the patient. For those patients who were coming not from Kota Kinabalu, they are from far, I would like them to go back to their GP, including your good self. That I would like them to see you, just to maybe to have a check on their wound, on their wound. You help me to check on their wound. And sometimes some of them, they have other medical conditions that need to be optimized. Things like maybe blood pressure need to be monitored closely, or diabetic, some impaired diabetic with a sugar of 8 or maybe 9, about 10, so that I would like them to go back to the GP to have them to be optimized further to improve the wound healing. However, after a month, for those patients who did a spine operation, I will ask them to come back. For those without implant, I would like to see whether the muscle strength of the back, whether there's extra physiotherapy is needed for the patient after the end of a month. Or for those patients with an implant, the early check on the implant on the X-ray will be able to tell me whether there's a potentially loosening or failure of an implant for the patient, and I would like to evaluate patient whether patient can actually go back to work, because the medical leave will end around 4 weeks time. Do I need to extend their leave or not? So for fusion operation, I would like to see them again at the end of 3 months, which is 12 weeks. Again, I will do an X-ray to evaluate the fusion, because we expect the fusion to take place after the end of 12 weeks, and resolving of the initial symptom, whether the radiculopathy pain or the back pain actually resolved by the operation, whether they're able to return to the activity or daily living by then. So if everything goes well by after 12 weeks, most of the time I will discharge them, and they will be returned back to their own life, unless there's other problem involved. So I always tell patients, you don't worry too much nowadays. I always give them a number to be called. Sometimes the patient need to call. Sometimes even without the appointment, I say less than a few days after you've been discharged, even before the appointment date, they have some problem like things like wound issue, the oozing from a wound, or the wound, the gauze came out, or there's a breakthrough pain. Initially not much of pain, suddenly they just twisted, or they just have a slip from the chair, then they have extra pain on the back or the surgical side, or they develop fever and chill, they may be sign of infection, or there's a new onset of symptom. Previously it's only some leg pain, now they have a lot of back pain or muscle spasm at the back. These are the patients that we encourage them actually to call us up, so the patient will not be feeling alone without any help. Of course, some of them they're scared to talk, they will do a WhatsApp, and this is the number I give it to them. You see the number is actually I would like to tell, number is actually is equivalent if you play with the keypad. You know that 77463 is actually the word for spine, so that it's easier to remember. Actually call the spine 0011 103 spine will actually reach us, and we are able to advise you accordingly. For most of the time that we are able to resolve the problem through the WhatsApp and also the phone call. And for severe cases, then we may need the patient to be actually to come back earlier to change the appointment itself. How about eating? Is there anything that I cannot eat? Of course, I tell patient, in the modern Western medicine, most of the time there's no need to pantang. You can eat a lot of things. Anything that you feel that you able to help you recovering, you go ahead. If there's any pantang in the family, in the tradition that you would like to follow, by all means go ahead. Things like people, Chinese may say you cannot eat prawn, you cannot take eggs, all these things. So to me, as long as the antibiotic the wound is healing progressively well, there's no reason for them to stop. However, if they believe in certain food that they may impair the wound healing, they are actually allowed to do so. Most of them we advise them for balanced and low-fat diet, rich in vegetable and fluid to ease in the bowel opening, so that they don't have to strain then when they go to the loo. And of course, during recovering they'll be less active, therefore they actually should take in less calorie, because otherwise you'll gain a lot of weight for the patient. Is there any activity that they should not do after spine surgery? Of course, I would like to tell them, you should not bend, minimum bending, you should not bend all the way. I know you used to able to do it, but because of implant and the wound, we would like to minimize on bending. You should not lift anything more than 5 kg. 5 kg is about a small pack of rice that you actually buy from a supermarket. So that will be a limit that the patient will actually know how much of weight they should not carry as well. Of course, they should not be twitching from right to left, because that will actually if you put a lot of stress on the implant or also the soft tissue that during the recovery. Of course, driving is most of the time is allowed unless they go through a bumpy road. so that the people are staying in very interior, the road are not well paved, then they have to drive, and these are not a norm for the patient. So if I cannot do a lot of things, is there anything that I can do to actually ease in my recovery? Yes, of course. You can actually take a short walk in a park. You can actually gradually increase the distance and the timing of the walk to actually, because all this exercise you actually train up the core muscle for the patient. And staircase most of the time is quite allowed. If you're staying in the first floor and second floor, of course you can go up and down. There should not be any problem. Of course, we are not asking you to go up and down all the time and everything. So as much as you can tolerate is allowed. How about physiotherapy? Do I need to undergo physiotherapy when I discharge home? That depends. You see, if a patient is able to walk, that's why it's important that I need patient to able to get up from bed and go to the loo and walk around the cubicle and in the room before they go back, because that will build the confidence in the patient, and also to build the confidence in a family member who actually see their loved one able to walk by themselves, and doctor actually allow them to do this kind of ambulation in the room, so that they will allow the loved one to actually to do the same thing, encourage them to do, and therefore it's a kind of physiotherapy by its own. So for those patients who may be a bit apprehensive, they don't want to move, when I review them, I may prescribe them a home-based physiotherapy. For those who may need extra may be coming back to the hospital to do a regular physiotherapy. Physiotherapy able to relieve some of the pain, especially patient got very severe muscle spasm. They build the strength and flexibility of the spine as well, and of course it increase the endurance of the strength of the muscle itself. Medication, patient will be given some medication when we discharge from hospital, and as long as the patient follow instruction of medication, including antibiotic and a painkiller, they are usually very safe. So those medication we give patient will not cause any harm to the patient, because the duration and the dose will be very well calculated, and patient will be being briefed by the pharmacy before they go back, and they may be aware and what to take and when to take the medication as well. For those patients who have a lot of muscle spasm, we may add on muscle relaxant for them. For those patients with a lot of nerve pain, we will nerve stabilizer, things like Lydica, gabapentin. And for those who are scared to strain, we may need some mild laxative for the patient to do a stool softener, so that they do not have to be straining during their lady bowel opening for the patient. How about bathe and wound care at home? So I will say that I will not disturb the gauze during the admission. However, patient will ask me whether I can bathe not within at home. Yes, you can bathe. Most of them we actually the gauze will be a waterproof tap, so that if you bathe your head and your body without and the water flowing down your back and through the gauze, it should not cause any disturbances to the gauze, unless you actually rub on the gauze itself. And you use the water to spray on the gauze, you rub on it, of course it will come out. So minimum disturbing, let the water drip down, usually most of the time for the first 5 to 7 days. After the 7 days, the wound is very stable. In fact, if you wet the gauze, by the time you can actually easily change it. Even you can do it on patient on their own at home without much of a problem. For those patients who need to be STO, usually it will be 2 weeks after the surgery, and this most of the time we actually ask them to go back to the GP. Sometimes they will like the GP because they would like to know the condition of patient, and because they're staying nearby to the patient, we will encourage them to whatever convenient for the patient. They actually can be STO in their own clinic. With that, I will end my talk. Hopefully we will give you some idea what to expect, because as a general practitioner, yourself or even your family, sometimes they ask a lot of this kind of question: what to expect, is it safe to do operation, why you do send me to see a hospital, and why the doctor say I need an operation. I think a lot of time we are not aware of this. We are very hard for us to actually talk to the patient. Hopefully with a talk that more or less you give up some information on what to expect recovering and how safe is the spine operation nowadays. Lucy, thank you very much.
All right, thank you so much, Dr. Chuah, for the updates. And we have received a few questions from our viewers today, Doctor. I'll go for the first question. This one is from Dr. Ko Leong Hin. He asked, is IGS and IOM a standard used by most of all orthopedic surgeons in most places, for example, Klang Valley, Doctor?
Yes, IGS is a robotic operation because you use instrument to image guided surgery, and IOM is actually intraoperative spinal cord monitoring. It's actually is a standard thing that we use nowadays because you see, the same thing if I go back a step, then I ask you whether you can drive a car without a reverse camera. Yes, you can do. Whether I can do a spine operation without IGS, without IOM, yes, I can do. But with the availability of this device in our hand, then of course I would like to offer to the patient that sort of, because if you improve on the safety margin and also the safety of the operation itself. So I would say that if available, I would still use it because it's actually quite a standard for a lot of places in worldwide, Europe and US. Yes.
All right. Next one, doctor. This one is from Dr. Vasanti.
Hi, Dr. Vasanti.
All right. She asked, her husband is 55 years old. He had sports injury during his school days, and he is a footballer. He has been having excruciating pain on and off for quite some time. He is diagnosed with gouty arthritis for his knee and ankle by the Hospital Queen Elizabeth Orthopaedic team. And her husband worry about paralysis and difficulty in walking and other problems as layman. So how to go about and how much and how long is the procedure for the intervention on the nerve? How many days need to be admitted and post-surgery when need physiotherapy, doctor?
I think a lot of your question being answered in my talk. So a lot of time we see for the condition of the husband, I think will be the problem is actually this is more of there's a wear and tear issue, is a degenerative process. So as you know, degenerative process is actually happen slowly. It won't happen overnight. So that the risk of getting patient paralyzed due to the condition is almost zero unless they really a bad fall to falling the condition. So that, but however, because this is actually a degenerative process and it's ongoing, as long as patient is still moving, the spine is still moving, every part of the spine will degenerate as the time goes by. So the condition is likely to deteriorate over the time because we are talking about years and years, not over days. Okay, so as long as you see that this condition is actually deteriorating and you have tried a lot of things, non-surgical conservative management, and they fail to relieve the pain, then it's time to consider operation. Of course, a lot of time is because we cannot make a decision because we do not know the condition of the spine. So that if best is actually, if someone can actually look into his spine and actually tell him what are the different options that we can actually give to the patient, because the patient will make the final decision. Because there's no way I can force a patient to do operation unless the patient agree for an operation, him or herself. So that but I would like to reassure you, if ever you need to end up in surgery, the risk of a nerve injury on board of what we have, the IGS, the IOM, the risk is very, very, very small. To have an iatrogenic injury to the nerve during operation is actually almost the equivalent to 1 in 2,000 or even less than that. So 1 in 2,000 meanings is for every 2,000 operation, there will be 1,999 should not have any problem. There will be one out of 2,000 may have some injury. Where I use the word may have some injuries, the injury can be a spectrum of injury. Means they can be very mild, just a transient weakness or transient numbness on the affected part, to a most severe with paralysis. And we are talking about on top of this nerve monitoring, we are talking this will be very, very low, even less than 1 in 2,000. 1 in 2,000 is 0.05. If you look at the actual scenario, what is the risk of 1 in 2,000 is actually almost the same as actually you play football during the raining and you be struck by a lightning. That will be the risk that you have as you are flying on a plane and the plane crash. That is almost the risk of 1 in 2,000, because the benefit for you to fly on a plane from here to Kuala Lumpur is much, but the benefit is much more than the risk. Therefore, you actually taking the flight, but you know that there's always a risk incurred. Spine operation is the same thing, because the benefit is actually much more than the risk. Therefore, actually we do think, we of course expect the outcome will be good. Okay.
All right. Next one, doctor. This one is from Dr. Kelvin Chu from Sandakan.
Okay, Kevin.
He asked, in case of any open spinal surgery, air will gain access into the spinal cord. I hope I pronounced it correctly. The aerosol. Yeah. How long does it take for the aerosol to dissolve? This is vital in medevac case.
Aeroseal. I don't quite get you, Evelyn. Aeroseal is mainly for laparoscopic operation, right?
This one, doctor. Can I show you?
I'm sorry, Kevin. I don't get you very correct. I haven't come across the word aeroseal. I cannot answer you. Maybe you can text us further to explain a bit. I will go to the next question first.
Okay, doctor. Let me check. All right, doctor. That is actually the last question for today. So, do you have any last remarks for our viewers today, doctor?
Okay. Thank you everybody for your lovely time. I hope I finish in sweet and short, so that it won't occupy everybody time. I think it's the dinner time. But I would like to wish everybody during this difficult period of COVID-19 to stay safe and actually stay healthy for everybody. And if you do come across your patient need to be asked about the safety of the spine operation and what to expect, of course, hopefully this talk will actually bring some enlightenment and idea that we actually know how to actually explain to the patient. So hopefully more people will be aware, because then they will be less scared. Otherwise, if you don't know something, you are more scared of it. Okay, thank you very much.
Thank you, Dr. Chuah. To all our viewers out there, I would like to bring your attention to the flyers on my left side. We are showing you our current package promotions for Chinese New Year, which is the heart screening package on 999 ringgit only, from the normal price of 1,388. You will also get a free My Heart program membership when you sign up for our heart screening package. If you are interested, or should you need further details, please do let us know. This promotion is valid till 26th of February 2021. Next, please don't forget to scan the QR code at the end of this live by using your MMA Doctor phone application to get your CPD point now. If you have any difficulties to scan the code, please click on the link in the comment section to confirm your attendance manually before 8 p.m. today. I will help to submit your attendance manually into the MMA system. And also, we have another online CME session with our resident orthopedic, arthroscopic, sports and joint reconstructive surgeon, Dr. Dhammalinga Mutia, on the topic of management of ACL surgeries on 5th of February at 6 p.m. Let me know if you are interested. We will share the details with you. So we have come to the end of our online CME today. Thank you so much for watching and listening to us, and see you next time. Bye.
Thank you. Bye.